Hey, everybody, welcome back to another edition of DPH Clinical. I am joined by the guys from Colorado Surgical Institute, and we got a great topic today. We're talking about something that I'm interested to hear about because I'm not really so positive and so confident in my knowledge in the subject. So, we're going to talk about can you convert and how to convert an overdenture case into a full arch case. And I guess my first question would be, I think everyone who's ever done an overdenture case would know, but why would you want to do that?
So I think there's a lot of confusion in the restorative and surgical planning aspect for these types of things. Dune and I see this a lot. Sometimes the ball gets, I don't know, things get a little confusing the more and more and more back and forth there is between the surgeon and the restorative dentist and who's doing what treatment plan, is it removable, is it fixed, like do they have perio, does the surgeon recommend something specifically, does the restoring dentist recommend something specifically? It gets very confusing. And I think a lot of the time patients end up in something that's more removable, which isn't bad, right? Because if someone has perio, maybe it is advised to give that patient a removable, or doing a telescopic slash like conus abutments to make something removable as well. And then when do you switch to fixed? And like, can you switch to fixed later, right? So it's really nice to give patients options for something removable, maybe at the time in their life when they're not behaving with their brushing and flossing, and then giving them later down the road a restoration that they can upgrade to, I think is really cool. A really, really good service to your patients, so they're not having to do more and more and more and more surgeries, right? It'd be really nice to just not have another surgery and you could just upgrade to a fixed prosthetic rather than something removable with snap-ins or telescopic crowns.
I can't tell you how many patients for the amount of work that goes into, you're extracting all the teeth, you're dropping implants, you're usually dropping, I guess, on the upper arch, probably the same amount as you would for an all on four or all on X or whatever you're doing. Maybe on the lower, you're getting away with two, but most people want to put three. I find most of my patients that go into overdentures just wish they would have spent a little bit more money and did the fixed appliance. I don't know if that's your guys' experience as well, but I can't say that my overdenture patients are all that ecstatic. I feel like I'm seeing them for adjustments. We're losing attachments. We're losing dentures are breaking, fracturing at the area where like we put in the housings. What would you say about that?
I think this conversation starts upstream and it can go one of two ways. So it's at the consultation, did you present a full arch? And if you presented a full arch and they chose an overdenture, which is a lesser option, then you've already done your surgery as if you need a full arch, created your prosthetic space for your full arch, angled your implants, and you just have special locators on there that allow you to give them an overdenture, but then easily transition into a full arch later. And then all you're really doing is records and charging the patient a preset prosthetic fee, whatever you determine in your practice, $6,000 to $12,000, depending on where you are geographically and how much time it's going to take you to upgrade them from something you have personally pre-planned to something that they can upgrade to now into the future. But let's assume that you did overdentures, now you do full arches and you never offered it before, or they have an overdenture, they walk into your practice and these considerations weren't taken. Well, you need to look at the prosthetic thickness. And how low can you go now, Briskie? Is it 11 on final?
For fixed,
Yeah, for fixed.
fixed minimum is 10, bare minimum 10.
Explain that a little bit more. 10 what? 10 for what?
So the thickness from the top of the prosthetic or the tooth, the incisal edge of the zirconia, down to the base of the zirconia, right? That has to be 10 millimeters thick. But this is for direct to multi-unit, right? This is when the zirconia is specifically milled to fit right on top of the multi-unit where there's no tie bases, right? But when you're using tie bases, that thickness increases. Now you're at 12 to 14. And 14 is still advised for like a tie base, because where it's going to break right where the tie base is. But when you're using milling something and that entire restoration is monolithic and it's one piece, it has just a ton more strength to it, right? So it's not going to break at where the tie base is. So now you can get away with 10 millimeters minimum, not 7 or 8, right? 10. And then you'll be just fine without any breakages, which is pretty cool now.
And when you're doing 10, then you got to evaluate the smile line to make sure you're not seeing the prosthetic transition line, or you got to educate the patient about like, hey, you might see this, or you got to make an incision and try to create tissue profiling and emergence profiles with almost like a pseudo FP1 type of an approach. So it's harder when they have a high smile line and you're converting an overdenture case to a fixed. Two is you got to look at the lip support. The flange of the denture has supported underneath their nose. And so if they're like more elderly lady and they're not used to seeing wrinkles there and you convert them to something fixed, they might see more wrinkles in that area. So you got to pre-talk about Botox and pre-talk about filler, or pre-talk about like, hey, this is going to happen and I don't do either of those things. And you might have to spend more money to get it taken care of. But guess what? You don't have plastic teeth and you don't have the majority of the roof of your mouth covered. And it's a far better option. So just making sure you have all these conversations ahead of time. But let's say it's pretty standard. Prosthetic thickness isn't an issue. Cosmetics isn't an issue. Transition line's not an issue. Then you order multi-units. You take out your locators. You screw in your multi-units. You torque them down to whatever the manufacturer's recommendation is. We like Neodent because of their Morse taper connection. You can do the same tightening across all of them, and they're just rock solid. And then you do your records, put them into a temporary, establish phonetics, tongue space, maybe talk about a sleep test to see airway. They're going to taste their food better. And then they approve their temporaries, and then you just convert that into some zirconia for them. And it's not that hard as long as you don't have to add more implants.
Now, what about if somebody, I'm thinking of when you can see that transition line because you didn't pre-plan it, you can cover that up with an overdenture, but then you're kind of in a pickle there if you're going to convert to fixed. Is that where you're finding out every single implant and just starting over?
So you can do two things. You can try to see if you can convert it to an FP1. So what you can do is you might have to add more implants if all that was done was 4 implants. And then when you make your incision, you can scallop the bone a little bit underneath to almost create like little pontic spaces in between your implants. And then when you make your temporary, you make it with pontics and an emergence profile. And when you suture them back together, you have to approximate the tissue really nicely to have a good emergence profile. And then even if they show the prosthetic transition line, it still looks cosmetic because you've handled the tissue appropriately. Now that's hard to do.
Yeah,
and so what I would
like
say is don't aim for that from day one. Aim for that when you have like 100 full arches under your belt. And then the other option, Briskie, what would be the other option without doing an FP1?
Yeah, you'd have to go to Overdenture, right? That's really the only way to do it.
You're stuck.
Because some of these really, really high smile line patients, it's really only like 10% of the population with that I'd see with full arches. It's every once in a while I'll see a patient with a huge smile line. And sometimes I'll actually have that conversation with them. And when it comes to the maxilla, I commonly now review a lot of options with patients. I review what an FP1 is, what FP2 is, what FP3 is, what snap-ins are, because I've heard of some litigious cases coming down the pipeline for doctors doing FP2s and 3s that didn't offer an FP1. I actually have seen that recently. So now I'm hyper aware of that. I do think it's because of the marketing aspect has been saying, hey, if you remove bone, you're a bad dentist, bad Paul, right? But it's not true. Like this is like a tested in time restoration. It's been there forever. But now all of a sudden, because some of these techniques are allowing us to go towards FP1s, some people are saying that you can't remove bone. So I don't know. I try to protect myself now and if it's not an option for the patient, which a lot of the time it's not, right? When they have bone loss and the FP1 is not an option for them, they need an FP2, FP3. So I just want to make sure I remind everyone out there to give all the options to your patients and let them choose it and have it kind of visible on a treatment plan. So that way later down the road, you can say, Your Honor, I did propose that treatment plan.
I'd like to ask, and this is just totally not me because I'm just so stinking smart. What the heck is FP1, F2, and 3? I totally know. I just think there's probably listeners thinking it, not me.
Yeah.
No, yeah.
Let me address what Briskie said also. If you didn't write it down, it doesn't exist. So in every consultation note, just make an explosion code or whatever that says presented FP1, 2, and 3, and snap-in, and denture, went over the risks, the alternatives, the benefits, the RABs, and then you can say a version of VICO, verbal informed consent obtained, and of course you're going to go get written consent as well. And it just pops up on every consultation note. So that way, A, you make sure you say it, but B, it's documented appropriately. And then what Briskie said is you have it on a treatment plan that you've presented, where then they sign at the bottom the option that they chose. And then at that point, you're tied in pretty nicely. And it's a very easy system to implement. And then when it comes to what FP1 and 2 and 3 is, I'll let Briskie take it because he explains it better than I do.
So FP1, 2, 3, right? There's FP3 is your typical looking fixed restoration where it looks like a block, and the block replaces, it's a long span bridge that replaces the gums and the teeth. So you see pink and you see teeth colors all into one piece. FP1 looks like yours and my smile, where you just see the teeth, you don't see the gums. FP2 is between it. It actually looks just like elongated teeth, a little bit funny looking teeth because they're a little bit taller. But most of the time when the patient smiles, they don't see that. They just see a few millimeters of teeth. They never actually see the transition where the gums are. So the transition line in FP2 doesn't really matter as much as it would have as in FP1, right? So it goes FP1 is just teeth. FP2 is elongated, little funny looking teeth. And FP3 is replacing gum tissue and the teeth structure.
Hey everyone, I just wanted to share a recent success story I just heard about. 6 months ago, Dr. Dushyant Patel of Sumner Dental Group in Tennessee reached out to Relevance Marketing because he wasn't receiving a whole lot of traffic from his website or anything online. Relevance expanded the online presence by listing the dental office in all the online directories with consistent information, which is super important, fixing any errors, along with redesigning his website using content that Google upranks, all the while keeping aesthetics and search keywords in mind. They then began to publish blogs and information relevant to dentistry using the search keywords for their area. Now, in just a few months, Sumner Dental was in position number 1 or number 2 on the Google Map Pack and organic listings for almost every single dental keyword. They saw an 88.9% increase in phone calls, as well as a 115% increase in interactions with their Google business profile. Now, if you think having your phone ring almost twice as often with new patients could really change your practice, well, you're right. If you're looking for a transparent, no contracts, no BS, and results-driven online marketing program, look no further than relevanceonlinemarketing.com. It's who I've been using for almost 5 years. Can't say enough good things about them. Hey, mention the Dental Practice Heroes podcast and you'll get your first month free. Go to relevanceonlinemarketing.com to schedule your free demo today. That's www.relevanceonlinemarketing.com.
And FP3 and FP2 are far easier to do prosthetically and even surgically. In the beginning, I would select cases that are in that realm versus doing FP1s. FP1s take a lot longer. Your surgical times kick up, your anesthesia times kick up, your prosthetic complications can kick up. The amount of post-op problems they have with inflammation in their gums in the temp phase and all of that kick up. So I wouldn't tackle FP1s if you're brand new to full arch.
Is there any surgeons that only do FP1s and it's kind of like a flex? Like, that's all I do, man.
I think anyone who says all they do is FP1s is like, okay, well, maybe that's not 100% true because not every case can be done as a FP1. Maybe that's all they do. They take the hard cases from other people and then other people are doing FP2s and 3s. So it could be factual when they say it. I just think for the standard person doing this procedure, you're going to see more FP2s and 3s than FP1s. And if you see a lot of FP1s, then maybe it's a diagnostic thing where some other options might need to be offered. If you're like doing 80% FP1s and 20% FP2s and 3s, it's like, that's typically the opposite of what presents itself in a regular practice. But again, if you're in Beverly Hills, maybe it's a little different. I don't know.
Yeah. I just don't see as many cases that qualify for it because you'll get a lot of cases that have bone loss or their vertical needs to be opened, so the teeth will get longer, right? So it always goes off of how much the patient needs to be opened, and if there's room, if the patient needs to be opened so much that the teeth look too funny, then you have to add gum tissue on it, right? Or if the patient's lost 90% bone loss and their lip line it was already even with their teeth, like how are you going to replace it with just some funny looking teeth? Your teeth would be like 14 millimeters long. It'd be some funny looking teeth there, right? So it's definitely case selection. I do think sometimes the marketing and the messaging online is a little misleading, that everyone just shows the FP1 case, but they don't show the other 500 cases that they did that were just like a regular case, right? Like an FP2 or FP3 case as well. So not every case qualifies for it. I just want everyone to be a little cautious over that when they're seeing it.
Let's say you've seen a patient that has an overdenture, doesn't like it. Maybe you guys want to touch on not going Like for a case that you can't take overdenture to fixed, what are some common issues with overdentures and how to approach those?
Retentiveness. Let's say the patient wasn't happy with how retentive it is. One, it could be you have to look internally and think, was it me? Is the denture hitting the gum tissue at the same time that the snap-ins are engaging, right? Because overdenture needs to rest on both the tissue and the implants, but mostly actually the tissue, as opposed to a fixed restoration is going to be supported only by the implants. So first, I always recommend people to look internally and think, man, is the denture actually touching the gum tissue all the way around? And is it snapping in at the same time that it's hitting the gum tissue? And if it is, cool. If it's not, then you need to reline it and re-pick it up. Then the second thing I see with overdentures is an overdenture that does snap in, but the vestibule is not long enough to where you don't get the retention from the denture itself, right? So and it usually is a lower, and that I see this on a lot. So you have like a lower overdenture, the snap-ins are there, maybe there's 3 or 4, and they're decently well spaced, and you really think it should be retentive, but it's just not. So in that circumstance, you actually have to do a vestibuloplasty on that type of case. You have to increase the length of the vestibule, right? One technique is called a Cousungeon vestibuloplasty. That's what I do for it. And what you'll do is you're making an incision using the lower anterior from about first premolar to first premolar, sometimes canine to canine, staying away from the nerve. And you're just letting the tissue granulate in, and you're creating attached mucosa. So not attached gingiva, which looks like our free gingiva, but it's actually called attached mucosa. So it actually looks like attached gingiva, but it's just slightly different in terms of the histology of it. That works really well to give the patient some more bone support, so that way the denture hugs the bone as well as the implants engaging in, right? That's your second option for in terms of finances. The patient just can't upgrade, right? Some people just won't ever be able to do it, which is perfectly okay. So I would do those things first. See if the patient, if it is attaching to it, right? If it is hitting the gums and is snapping in, and then also see if the vestibule is long enough and it is engaging. Now, if you've kind of went through both those options at that point, you need to upgrade, right? You need to upgrade the patient. So like, what do you do, right? One option I'd say at that point is you could transition the patient to a telescopic restoration. So CONUS is the name for it, or a lot of labs will make precision telescopic crowns, which is if you have 4 implants, every implant has a little post that sticks up about 4 millimeters. And each of those posts is parallel to all the other implants. So it's basically a custom abutment that's parallel, and it's friction grip. So there's a taper on the top of the crown, and that taper, I think, is 4 degrees. I could be wrong. I think it's 4 degrees on it, because once you get less than that, it'll actually become cold welded. So I'm pretty sure it's 4 degrees. It might be 7, but I'm pretty sure it's 4. So it'll go down and it will engage friction fit on top of the teeth. But for that, your minimum thickness is 12. So you have to think if that's even an option based for your patient, right? So this kind of brings us back to like how you get a record. So have you ever made a denture before, Paul, and the teeth turned out like really small, and you're like, this lab sucks. Like, why are these teeth so tiny?
Yeah. I remember doing one where the try-in, it was like, these are kids' teeth. What are we doing here?
Yeah, this kid's teeth. Yeah, exactly. I've done it so many times like that by accident, and I just didn't even realize what I was doing wrong at the time. And I wish dental school would teach this. But all you do is you open the patient's vertical dimension up. All right, you have to open them up, and how you do that is you buy what's called a VDO gauge on the eBay. I think they're about $80, and you measure the distance. It's actually all based on a law of golden proportions, and what they say is the middle of the eye to the corner of the lip will equal the measurement from the bottom of the nose to the bottom of the chin. And this is when the patient's in a resting position. So you just kind of have to let them rest and have them close till their lips touch. And in 98% of people, that measurement's actually the same. So it's pretty cool. So you can open up the patient to the measurement of where the middle of the eye and the corner of the lip meet. And then when you do that, that's how you can remake your prosthetic, or you can reline the denture. So that way the denture is thicker.
And let's say you do the VDO, it's perfect, and you still have kids' teeth. You haven't reduced the bone enough to create space vertically that way. To go to Briskie's comment about conus and telescopics, only really good labs can do this right. It's a very lab technique sensitive thing. And if they're off a little bit, they're just so loose. Or if they're on too much, they're so tight, the patient can't get them off. And now you got a fixed issue. And then you got to loosen it up chair side, and then you overdo it because it's a degree. And then now the whole thing is loose and you're remaking the whole thing. And so conus and telescopic, pay the lab bill on a good lab if you want to test some of those out, if you want to go that route. And then he mentioned a few things with overdentures. I think if you don't have a metal framework in your final overdenture, you're asking for potentially some problems because patients might drop these things. They fracture through the pilot hole you make in there to pick up your, what's that thing called?
The housing.
The housing, thank you. So they just break right through that housing. Typically speaking, I'll make an immediate that I'll pick up for them, but then I also will remake the denture. I factor that in to every case. You're getting another overdenture at the end of this. We're going to dial in cosmetics. We're putting a metal framework in this thing. And that way, that's like my long-term overdenture. If they're only in an overdenture for a short period of time, meaning like 5 years or under, then I'll do a traditional pickup type of a deal on those.
But this is why we do the bone reduction kind of like we're doing a fixed case, right? Because if you're doing the bone reduction for a fixed case, which is about the same as literally what you need for a conus and what you need for telescopic and really what you need for an overdenture case too, it's usually about the same reduction. So when people are planning their overdenture cases, I really recommend them to make sure they factor in the reduction portion so the patient can go between any of the options that they want to.
Yeah, makes sense. All right, talk about your courses you guys got coming up in October and November.
We're sold out for the year except for our November course. So come November, we're going to be doing, it's like at the end of the year, we typically just do one where it's like, hey guys, it's the end of the year. We want to focus on the fun stuff. We're going to be running full arch. We're going to be running some sedation, but we're mainly going to focus on full arch and single implants. And so I did a call with this doctor named Peter the other day, and he's like, yeah, I got 10 years of doing neodent. Is your singles course too easy? I was like, no, man, like we do this call for a reason. I'm going to set you up with all hard ones. Anyone who's trying to do full arch or just do singles and you want like more complex ones, you want easier ones, reach out to me and Dr. Briskie. We set up the level of difficulty for you. You got a few operatories open for November. Then after that, we're going to roll into next year. You can sign up for IV sedation anytime you want because we have 20 hours of it virtual. So you can knock out 20 hours at home before you ever have to come in person and start doing like ACLS and doing the reps and the phlebotomy and learning where all the vasculature and things are and learning the meds in real time. So with IV, if you want to get started, that process is long depending on your state. So I would say sign up for the IV, get the virtual component going as soon as possible, and then we'll contact you and we'll coordinate you with the implant and wisdom tooth course and just make sure it all works together. So reach out to us at coloradosurgicalinstitute.com, and we really have anything set up for you, but I'm super excited about our November course and IV sedation specifically.
Awesome. Well, thank you so much, guys. We'll talk to you next time.
See you, man.
Awesome. Thanks, Paul.
Hey everybody, this is Dr. Dune from Colorado Surgical Institute. Just wanted to give you guys a shout out and let you know about the program. We have full arch surgeries, we have lateral sinus lifts, we have block grafting courses, all done in one weekend with the whole digital workflow with photogrammetry units, scanners, 3D printers, milling, you name it, anything regarded to full arch we cover in depth. We also have a PGCA course. What that is, it's the Postgraduate Clinical Accelerator course, where we are going to be covering wisdom teeth, single implants, and it can be complex single implants with vertical sinus lifts. We'll also be covering full arch extractions with ridge reduction, bone grafting, PRP, suturing, and we also will have a course on socket preservation. So if you guys are interested in any of those courses, please reach out to us at Colorado Surgical Institute. The code is